Okay, good morning, good afternoon, everyone, and welcome to today's webinar, Addressing Data Science Challenges in AI in Health. This webinar is brought to you by IDRC, TGHN, Jacaranda Health, and hosted by the Global Health Network. My name is Prince Ebenezer J, and I'm delighted to have you here with me today. Just a few housekeeping before we begin. Due to the number of participants, your camera and microphone are disabled. Please use the chat feature for introductions and to report any technical issues you may have. Please use the Q&A feature to post your questions and comment. You can do so anonymously. And we'll do our best to go through as many of the questions as possible within the Q&A session. This is an overview of the registrants for this webinar. Like I mentioned, my name is Prince Ebenezer J, and I am the coordinator for the AI for Global Health Project, the Africa region. I am also the AI specialist for the Global Health and Infectious Disease Research Group at KCCR, KNUST. Part of the panel today would be Abhishek, Katarina, and Stanislaus. They'll introduce themselves when it's their turn to speak. We'll go through a few remarks and introductions, and then we'll go through generative AI for outbreak analysis. We'll look at time series analysis of EEG data for epilepsy diagnostics in LMICs. And then we'll look at improving maternal health outcomes in Kenya using AI, and then close.
Sorry, Prince, could I just interrupt you just a second? Could you go back to the second slide, please, just to explain how the language interpretation feature works? Cheers. So it's a slide before that.
Excellent. I think I missed this. So sorry, I missed this one. The workshop is being recorded and we'll share it on the AI for Global Health Knowledge Hub on the Global Health Network. Whilst this is happening in English, there's simultaneous translation being provided in Spanish, Portuguese, and French. When you look at the toolbar at the base of your screen, you will find the interpretation feature. Kindly click and select your desired language input, either Spanish, Portuguese, or French. Excellent. So for certification, if you wish to receive a certificate of attendance for this workshop, 1, please complete the Global Health Network workshop feedback survey that we will share at the end of this session. Number 2, you must also participate and spend at least 80% attendance for the workshop. A code and a link to the survey will be shared at the end of the session. Please don't forget to include the title of the event and the code provided when requested. It will take approximately up to about a month for your certificate to be ready and sent to you. You can find more information on the site provided. Our goal here is to understand the basic principles of AI, its application in data science. We will try to identify key trends and challenges in integrating AI into healthcare systems, look at generative AI and its role in analyzing disease outbreaks, and then look at how AI is helping to improve maternal health outcomes in Kenya. There's some resources that you can refer to for further information. So before I invite the first speaker, I'd like to give a background to what we are going to talk about. Now, generally, if you check on the internet for what artificial intelligence is, you will find that it has traditionally been defined in the context of the Turing test. That is trying to make computers intelligent like human beings. This is correct. However, I feel it still lacks some level of clarity. That is, what actually is intelligence? How do we describe this quality that sets human beings apart? Now, artificial intelligence is the science of making the computer intelligent, specifically being able to do 5 things. Number 1, draw conclusions, interact with humans, evolve, summarize, and learn. Once we consider this definition, then we can distinguish between specific technologies and then artificial intelligence in the context of healthcare. So for example, you can have a very intelligent solution like using drones to deliver medical supplies to hard to reach areas. But while this solution is intelligent, it may not necessarily be specifically artificial intelligence. Data science, on the other hand, can be described as the science of extracting meaningful insights or knowledge from data. Data is simply whatever is recorded or captured by some measuring device or by some person. When data is qualified and considered in a particular context and given value, we can call that information. Evidence is information that comes from a process ensuring its soundness over a long enough time scale to be relevant and after testing for any scientific errors. If you take the earlier definition of AI in the light of what I just described, then it becomes obvious the role that AI can play in data science. That is, it can assist in curating evidence to improve health outcomes. It could also assist in providing information, depending on how you think about it. There's a first group of people who feel that AI systems should take over completely and extract either evidence or information from data. Then there are those who feel human beings should do that because it's difficult to model things like intuition. But more recently, there's a middle ground between the two, so-called expert systems, where human beings and AI systems work together to make meaning out of data. So the goal of this workshop is then to consider what challenges might we encounter in the quest to work with AI within the context of data science for health. And today we will discuss 3 exciting AI-based solutions. And throughout the talk, try to highlight how these approaches are helping to transform data into evidence and into information. So with that, I'll invite the first speaker for today, Abhishek.
All right, thanks, Prince. Let me share my screen. All right, can you see my screen, everyone? Okay, great. So, hi, everyone. I'm Abhishek Dasgupta. I'm a senior research software engineer in the Oxford Research Software Engineering Group, and that's based at the Doctoral Training Center in Oxford. And I'm part of this organization called Global.Health, which is first of its kind repository for line list data. So if you're not familiar with line lists are detailed information at the patient level of the demographics, contact information, and travel history. And this is especially useful for early outbreak analysis when people are trying to determine whether the outbreak is viral or is how it spreads, what's the reproduction number, how infectious a particular disease is. So early outbreak analysis is the area that Global.Health operates in, and we are one of the first to give the early line list data in COVID-19. So to give some context, the Global.Health organization started up in 2020 in the early days of the pandemic, and they published a line list consisting of, I think, a few million records in the early days. But we ran into issues with Google Sheets, so we started building a data platform, and that's what I've been doing for the last 2 or 3 years, is building the data platform at Global.Health. And now that the pandemic is is kind of over in a way. We have also looked at other outbreaks like the mpox outbreak in 2022, and we were one of the first line list providers in 2022 for mpox, and our line list was used by various organizations. Yeah, so that's what we do. Essentially, we do early outbreak analysis and data curation. So the objective of this talk is, how do you make this analysis accessible to a wider audience? Now, of course, you have this line list and it's great, but it has a lot of data and a lot of columns, and this is not really accessible for someone who is not a data analyst. Like, you can do some basic stuff in Excel, but you probably need to go into something like Python or R, especially if you want to do nice plots and charts. It's not that easy. So for example, I'm looking at here on the screen is the list of columns from mpox. And see there's like 35 columns. It's a lot of cases, about 70,000. Many of these columns are sparse, so there's not much data in them. You can see like contact data particularly is not there. And then, but you do have some of the other columns are quite complete. So how, if I give someone this data set and it has all these columns, like how will they go about doing this? How will they go about doing this analysis without maybe knowing any coding? Maybe you're a government official and you want to take a look at this, and can we do this without coding is the question that we wanted to answer. And of course, this, the title of the talk does say it, generative AI will be used in some ways. So this is another example of the disease outbreak news data. So the WHO produces regular bulletins on new outbreaks, and they call it the disease outbreak news. Now, the disease outbreak news is mostly unstructured text, but some people over at Georgetown think they came up with this. They went through it, they parsed it, and they put it in a nice data set in Excel. And with a number of columns, like you have disease and when the outbreak started, how long the outbreak went, how many people died. It's a very useful data set. But again, it's the thing of like, how do you interpret this? How do you look at it? How do you slice and dice the data? Again, without knowing coding necessarily. So this is the challenge. Like, we want to make this openly available data, but you also make it accessible to as many people as possible. And previous to generative AI and large language models, this wasn't something that was very easy to do. So what do you want to get? Like, so this is the screenshots from the paper that did the disease outbreak news, and one of them shows like the top diseases, the top 10 country disease pairs, and also like just the number of outbreaks by country, and it's a nice choropleth map. So can we get these tables? Like, if I'm an analyst and I just wanted to ask this, can I get these things without really doing any coding or trying to load it in a data analysis tool like Tableau or Excel? And the solution is, well, generative AI. Like, of course, when ChatGPT came out in November 2022, it was, I think it was a pivotal moment in which people realized that, yes, you could ask these chatbots natural language questions and get fairly intelligible answers out of it. And there's a lot of emergent capabilities, right, where you've got these chatbots generating whole videos out of short snippets of text. But of course, the main disadvantage of generative AI is hallucinations. They tend to make things up. So that's of course an issue. So to address all these things, and to keeping in mind that we don't want hallucinations as much as possible, so we created this tool called Data Chat, and currently it's we're testing it privately with a few partners to ensure that, of course, we're not releasing a tool that's going to just lie about the data. I think we have taken some good steps, and I'll explain what we're doing to reduce hallucinations. But essentially, this is how it looks like. you have a chat interface, and we use OpenAI. At the moment, there are hooks in it, so you can put in your own language model if you want to, but we find that OpenAI is fairly cost effective if you're not doing too many questions or queries. So initially, we have loaded this up with a few data sets. So one of them is the disease outbreak news. That's, you look at it here, select data set, but also looking at some other data sets like our mpox line list. So essentially, you just ask it questions now, right? So instead of loading this complicated data set in Excel or R or Python, you don't need to do that. You just ask like, hey, give me a map of cholera outbreaks, and there you go. That's really it. And here's another example. Maybe show me a graph of flu outbreaks, right? So here, it looks at, and what it does, and I'll explain the architecture of how this is working. It converts this into a SQL query. So if you're not familiar, SQL is a language. It's called structured query language for looking and querying databases. The advantage of SQL versus Python and R is that SQL is also fairly human readable. So what DataChat does is that it'll convert the query that you get into a SQL query, and then it will give the result from the database. So here's how the whole thing works. You have a query, and what we give to the language model is a database schema. So that's essentially very basic data dictionary, a list of columns, the type of the column, and in some cases, what the distinct values within the columns are. For example, if it's a country, then the list of countries, and so that bit is sent to the to the language model. Rest of the stuff happens entirely locally. So this green bits, the stuff in pale green, that's what's going out of your network. And once you get the query back from the language model, you look at the database, you get the data, and once you get the data, you can visualize it. And currently DataChat uses some heuristics. So if you've got like country columns in the data, it will try to show you a map. If you've got locational sort of latitude and longitude columns, it will show you a dot map of the of your data. If it's count data, like histograms, it'll show you a bar chart. And in all cases, of course, you can see the query. And I think that's the main thing here. You don't have to trust the language model. You can see what it is trying to do. And that transparency, I think, is very important when you're trying to work with AI that's this complex and this much of a black box. And especially if you're using proprietary models, because they can be even more of a black box. So it's important that the AI, the output of the AI or the working of the AI is transparent to people. And that's what I've tried to do here. Right, so I will try to do a live demo and see if that works. If not, if that doesn't work, I'll show you a few more slides of what DataChat can do. So just give me a couple of minutes. Let us share this. Okay, so here's DataChat. And right now, we are on the outbreaks. So a very simple thing to test, which I always do, is how many outbreaks do you know about? So since we're using OpenAI, you will need an API key. The API key charges you per token. So if you use it like on a standard day, like maybe 10 or 20 queries per day or 100 queries a day, it'll probably do like about $5 a month, not more than that. Like I've been using it heavily and I've not crossed $10 a month. So how many outbreaks? Okay, you get the count, you get the query. Okay, so map of flu outbreaks. Okay, that didn't work. That's the nice thing of a live demo. Sometimes things don't work, but it's all valuable feedback. Okay, so the cholera outbreak thing works. So one of the reasons why this might not have worked is we're trying to do flu, but of course, if you look at the original data set, it doesn't have flu, it has influenza A. Sometimes the mapping works nicely, and I was hoping that it'd work here, but in this case, it didn't work. So I'm looking at the map of cholera outbreaks of the country. Again, does the query gives you the data, and you can always look at the data here. So here is your country ISO3 code and your cholera outbreak count, and that's displayed as a nice map. So one of the examples I was trying to do is give like the top 10 disease country pairs, right? That was something in the table, and let's see if that works. Yes, and you can see that it's giving you the results exactly as you looked at in the table. And it could do a bit of formatting with the country full names, but essentially, what it's doing is grouping by the disease and country, and we're doing it in descending order with 10 pairs. Okay, now let's look at mpox. Okay, so how many confirmed cases? Okay, great. So filtered by status confirmed, that's fairly easy. Let's try to do a chart. Timeline of confirmed cases here in the UK. Yeah, okay. I have to do some work. Maybe I do map of confirmed cases in the UK. Okay, didn't do map. It did give me the total count of cases in the UK. So here's the thing with LLMs, it's not always predictable what it's going to do because they're not reproducible in the same sense as your standard Python or R tools. But in all cases here, you can see what it's doing. So you can see it's trying to not do what you want. So you can try to change the query and see if that works. Let's do top locations in UK by confirmed cases. Okay, that's not working. Yeah, it's this. Okay, let's do something else. How many recovered cases? Okay, so that works. So here, for example, you didn't have to figure out like which field has this, right? So because the data scheme is passed to the large language model, it knows that the recovered thing is in outcome, and that gave you the answer. Let's try to do maybe a timeline again. Okay, yeah, so there's some bug. I'll fix that. But okay, let's try to do a data set on cars. So if you know the empty cars data set, it's just a database of cars. So which is the car list cars with above average horsepower. So it's not restricted to infectious diseases generally. I know it can do arbitrary databases. Of course, it needs a bit more of work, as you can see with some errors that I got. But here, for example, you can see that it works nicely, looks at the car model, horsepower, and gets the average, filters by that. So yeah, I'll stop sharing now and go to the rest of the presentation. Share screen. Okay, so here's some more examples of queries that I've done. So you can do like, some queries, sum over a column. You can do timelines, histograms, maps, which should have worked, but I'll take a look why it's not working now. And there's also a Jupyter Notebook interface if you want to play around with it in a more standard, data analyst pipeline kind of thing. You can just ask it questions within this, and you'll get data frames out of it, and then you can do stuff with the data frames. So you can do it as part of your analysis pipeline as well. So we evaluated. So we're doing GPT 3.5 because, well, it's cheaper and it's faster in some sense. But GPT-4. So if I did this with GPT-4, probably would have got better results. So GPT-4 has 95% accuracy for a test set of 65 questions. GPT 3.5 lags behind at 85. The open source models, they don't perform that well. But this was taken a while back. Things are changing quite quickly. So we'll go back and revisit this. Right. So pros and cons. Generative AI is quite good, if not always correct. I think we saw a good demo of that today. It supports languages, multiple languages, which I'll try to do in a demo next time I do this, because it converts all the languages into its own encodings. So it doesn't matter really what language, as long as it's a really fairly well-known language, you can ask it in Portuguese or Spanish, and it'll give you the same result. In the data chat, the LLM never sees the database, so your private data never leaves your server. So that's a good thing. And SQL makes it easy to read. And disadvantages is that it's a new thing. It's harder to test. It's not really reproducible. And since it's SQL, you can't do very complex stuff. So I will skip this since I see we're at time. But this is a slide looking at how we will integrate AI generally into the global.health stack. So next step is, we do validation, we fix the errors, and we're doing, private testing now, and try with more data sets, particularly global health data sets, open data sets, so that, we can ship it as part of, the standard tested introductory thing. And later on the year, want to release it for wider testing and also support language models from other companies like, Google and, language models from Hugging Face. So thank you for listening to the talk, and yeah, you could feel free to contact me with questions, and yeah, thank you for listening.
Excellent. Thank you so much, Abhishek. So essentially, this is an AI-powered way to mine data when you don't have strong programming skills or so. That will no longer be a limitation. You can speak naturally, and you can naturally query several data sets and then have very coherent responses. I have two questions for you from the panel.
Sure.
The first is it possible to see the trends of a specific outbreak per country?
So in terms of trends, whether it's increasing or decreasing, SQL doesn't let you do that. You can look at timelines, which does work. It's just like, I think I might have updated a few dependencies, and that's why giving this pandas error. But yeah, you can filter things by country and look at the data, but it's not going to do things like reproduction number for you. That's not the purpose, because it's limited to SQL. Yeah.
Excellent. Then the second one, can we use a direct link to any database instead of uploading the files?
Not at the moment, but I'm moving stuff from, so right now the backend is a thing called SQLite, so I'm moving it to another backend, and that will allow you to download files in CSV or Parquet. So I know if you don't know Parquet, it's a columnar data format. So then you'll be able to, instead of uploading, you'll be able to paste it as a link to a box on the side. But yeah, it's planned to have that.
Excellent. Maybe a final question from me, just for our student audience who may be interested in exploring this research area. What do you see is likely to be the future of this area? What are some of the exciting problems you envision this sort of approach will eventually solve?
Well, I mean, it's very hard to predict this area because things are moving so quickly. So, we might come back in 5 years and everything is taken over by AI bots and doing our data analysis for us. I do see a future, especially in data analysis, where, reproducibility and correctness is very, very important in research. So I don't see them these tools taking over completely, but in some sort of they'll be a sort of research assistant, doing your initial data cleanups. So, if you have looked at voice assistants, right now they turn on off your lights, and you can set things on your calendar. And I envision, like in 5 years, people will be talking to data assistants, and they'll be doing the data cleaning. It'll still be verified by the human, so the human is in charge, but they will be doing some of the data cleaning in a interactive manner. And of course, this also opens up the whole data cleaning thing from being a niche reserved for data analysis with coding experience to the wider public, which will be a very interesting shift if this takes off.
Excellent. Thank you so much, Abhishek. Please note we have seen your questions, and the speakers will respond to them in private if you're unable to do so openly here and now. Next, we'll move to another wonderful presentation by Katarina. She'll be talking to us about epilepsy and how AI-based solutions can bring some improvements along that line. So Katarina, over to you.
Hi, everyone. Let me just share my screen quickly. Yeah. So let me start by introducing myself. So I'm Katarina. I'm a DPhil student, a PhD student at the University of Oxford, where I also did my master thesis, and that will be the topic of today's talk. So the goal of my presentation will be for you to give you a little bit of insight what it looks like to develop a tool, well, within a research environment, but also like the design and the challenges of early stage development. And specifically, I will focus on epilepsy diagnostics in low and middle income countries. So I will start by giving you an introduction, a little bit of background information, some of the challenges the world is facing and I was facing during my research. And then I will introduce the project to you and my team that was behind me, because I couldn't have done any of this alone. And then I will present to you the solution we came up with and how we envisioned it to work. But I will also focus a little bit on the data that we used for the development and the pros and cons of using this type of data. And finally, I will present to you the actual network that I designed and what kind of tweaks I made to it to make it explainable and transparent. So let's start by telling you a little bit about epilepsy. So epilepsy is a neurological disorder that affects more than 50 million people worldwide. And the WHO has given also some shocking statistics that more than 80% of people with epilepsy live actually in low and middle income countries. And this is a huge issue. And one of the facts that kind of fascinated me the most when I was doing this project is that at that time in Kenya, which is a country that has about 50 million people, there were, well, the numbers vary a little bit, but there were up to 20 neurologists in the whole country, whereas in a country like the UK, currently there's about 950 neurologists registered, and you can clearly see this gap. So the burden on the healthcare system is huge. Well, and that kind of ties into the third point, that a lot of people remain undiagnosed and untreated, but the burden on the healthcare system is just one side of the story. But some of the research revealed from other members of my team is that in some of these countries, there's a big social stigma around epilepsy, but there's also a gap in knowledge, which is why people often don't recognize that the symptoms they are experiencing can be related to epilepsy. But to finish on a more optimistic note is that up to 70% of people with epilepsy could live seizure-free if they were diagnosed. So I will tell you a little bit now about a project I was a part of. So this project is part of the Oxford Martin School, and this team has recognized that there are certain gaps to be filled, and that is within the knowledge, diagnosis, and treatment for people with epilepsy. And the goal is to do that through the implementation of ethnographically grounded digital technology. So the technology that we aim to design is in the form of a portable EEG device that trained healthcare professionals can take to rural areas and diagnose people within their communities. And this is very important because what data has showed us is that in some of these countries, the nearest hospital would be hundreds of miles away. So it wouldn't be possible for patients to come into, well, definitely not regularly, to come into these clinics and get tested, diagnosed, and treated. So we want to basically bring healthcare to them. So when this clinician or healthcare professional takes this EEG device to the patient, they can talk to them. And the way diagnosis, from my understanding, works of epilepsy is that we would do a study, like recorded brain waves. We will look for something called IEDs, and I will explain a little bit what that is. And then combining with the patient history, we will come up with a diagnosis. So the goal is for this device to speed up the process of analyzing the EEG data, and then the healthcare professional can refer patients to the hospital if necessary. So I want to mention my team that I was working with. So these 6 people listed are from the University of Oxford, and the top 3 are from my department, the Department of Engineering Science. These are my main supervisors, but I also did collab with other people as well. And I here will mention Arjun, who was the PI of the project, then Gabriel, who is clinically trained and helped me understand epilepsy better from a clinical side and implement, well, changes to my design according to that. And finally, Sloan, who did the ethnographical work and informed us of the design choices we need to make for that. So another thing that I want to add is that none of this would be possible if we didn't have collaborating sites in these 5 countries who gave us feedback from people in the country which would use the device, the healthcare professionals that would use this tool, and that helped us even more and informed our design process. So it does take really a multidisciplinary team with a range of skills to come up with something like this. Okay, so that brings me to the aims of my project. So the first one being to design a clinical decision support system. So we don't want to replace doctors. This device should speed up the process and help doctors by reducing this burden, allowing them to see more patients as quickly as possible. Then we would want to create an explainable and transparent AI solution. And as you will see, this is done in 2 ways, but the main one being to have this pipeline which will reflect the decision-making process of an expert, so that hopefully they can trust the results a little bit better, a little bit more, and well, to also be able to notice mistakes when AI makes them. And the way we would do that is by being able to interpret the decision-making process. And finally, I think what was specific about this project is that the pipeline should be fully automated and fit a tiny ML on a microprocessing chip. And why this was important is because in these remote areas, as I mentioned, we might have limited server accessibility, we would have limited battery life. So we would want to see as many patients as possible. So this needs to not spend a lot of energy and a lot of battery. And finally, how do we then diagnose patients? Because from our understanding, it is relatively easy to diagnose someone with epilepsy when we see them, that they are seizing, but together obviously with the patient history. But when we see someone for 5 minutes or for half an hour and they're 100 miles away, so we can't go see them regularly, it's a bit harder. And the way people usually do that is by analyzing their interictal EEG, which is the between seizure EEG or brain waves of a patient, which are seemingly resting. And we are looking for some spikes that are called interictal epileptiform discharges, basically a couple of spikes that have a specific morphology and that are indicative of epilepsy. With the crucial word here being indicative, which means that people with other neurological diseases such as Parkinson's or Alzheimer's can have IEDs or something that looks similar to IEDs, but healthy individuals as well. So we need to combine it with the patient history. And as I said, The visual inspection of EEG signals is the gold standard, but it is a very time-consuming process. It is error-prone, and it is very subjective, or in this case, it varies between clinicians how they would annotate the EEG data. To the solution itself and how we envision the prototype to work. On the left side, we have the headset with electrodes that are configured in the standard 1020 configuration. And the pipeline would work then like this. We would record the EEG data for 30 minutes, but after 5, we would pass it through a signal quality detector to see whether all electrodes are connected, whether the level of noise is acceptable, and so on. And if nothing's flagged, we continue recording. After the recording is finished, we pre-process the data and pass it through our trained network. And then after the network, we combine that information. That's where the clinician comes in and interprets the results with the patient history and diagnoses the patient. So what makes this network a little bit specific, well, definitely makes it different than the IED detectors that existed when I was doing this master thesis, was that it was not detecting only IEDs, it was detecting also artifacts and other background noise. And basically, we were forcing the network to distinguish between those 3 categories. And why this is important is that in previous research up till that, people were usually trying to distinguish between IEDs and neurotypical samples, which was a little bit simpler than what we are doing here, because artifacts and IEDs have shown to have similar morphology or similar shape. So they're often confused with each other, and we don't want to have that. So we try to detect all 3. Okay, so now on to the data, because as you all know, the model is only as good as the data we are feeding it in. So I will tell you a little bit first about the data that I use. So I used an open source data set that had more than 15,000 training and testing samples. It had EEG data, which were divided in 1 second long segments, and these segments were annotated. And it's one of these 6 classes. For the purpose of this presentation, you just need to know that the first 3 classes can be classified as IEDs, and everything else is the artifacts and other. And it's very important to say that they were labeled by clinicians, because that brings us to the main challenge of this project, and that was that not all of the data was labeled. So what we could see is that clinicians in some cases would analyze only the first couple of minutes of an EEG recording, which could be hours long. And then if they see that a particular patient has IEDs for like minutes in continuing form, they would just label the first couple of seconds. So even though something is not labeled, that didn't mean that it was abnormal. So that is one challenge we had to overcome, because for a clinician, they can label just the first couple of seconds and then they see automatically the rest. They don't have to physically label them. But the labels for training are set, which was either epileptic, neurotypical, or other abnormal EEG, we were deriving from doctor's notes. So this is the patient information that had information like patient's history, brief patient's history, medications they took, diagnoses they had, a description of the EEG data. Which brings me to a small point that the data that I was using was anonymized fully. And this is hard to do when we have free text data, because doctors would just describe what they're seeing. They could use names, so it takes a lot of effort, and it's not really that straightforward always to do this. But the good side about using an open data set is that we can have access usually to much larger data. We can have, it is cost effective. This one was free to use. We can easily compare it to other models, and then other people doing the same research can compare it to ours because we're using the same data. But on the other hand, we have a problem with the data quality because we are not reflecting the patient population we are seeing in these countries. This particular data set was mostly used on patients from the United States. And then there's also some bias, inherent bias that goes with this data, as with the specific, for example, distribution among the distribution of ethnicities amongst the patients and so on. So the better way of doing it would be to use a closed data set that is tailored to our specific requirements, but obtaining such a data set is usually very expensive, and then it is very hard to reproduce the results, and it's usually there are problems with anonymizing the data and privacy and so on. So for the purpose of this thesis, we use for this prototype, we used an open data set, which made sense to use. And then you can see quickly on the right-hand side, for example, highlighted is what we call a GPED, which is a form of IED. And it's taken from this website where you can go and play around, and they can show you the different IEDs on adult EEG forms. Okay, so now moving on to the two design changes that we made to make this model more interpretable. This is another thing that wasn't done as much before, and this is how we input the data into the model. Usually models would take 2D input, so we would have channels on one axis and we would have time on the other one. What we did here is we rearranged it into a 3D input, so that we place channels that are physically close to each other, also close to each other in the data. And with that, we aim to push the model to learn that data, which is physically close to each other, that relationship means something. So what you can see on the left, just to recap, is these circles are the different channels or electrodes on the EEG. And then what we have as a channel or link is the difference between two neighboring channels, between two neighboring electrodes, so the difference in voltage that we then put in. And we came up with two solutions, something that I called creatively simple and a wide 3D segment. So for the simple one, it is basically like a square input, and it achieved a higher performance than the wide one, perhaps indicating that there is something to be learned from this rearranging the channels. And then on the other side, we have something that I call the wide 3D segment. Basically, the point being that we have 3 channels, making it suitable for to be used when we do transfer learning on pre-trained models. And in this case, it was applied to, for example, Inception V3, which was pre-trained on images, which have then 3 channels. Okay. And this is the overview of the architecture of the model. And I will not dive too deep into what I did, but I want you to focus on a couple of things. And that is the first thing, that this network is very small. And we try to design it to be very shallow and to be as wide as possible, but not use too much memory, for the reasons I mentioned before. So we wanted to fit on a tiny ML, so we don't want it to use a lot of memory. But also on the other hand, we don't want it to be too deep, because it makes it more difficult to interpret the results and to interpret the meaning of the weights in the different layers. So what we did is we used inception layers to make it as wide as possible. And this is an inception block from GoogleNet, which is a network that Google designed, and now it's almost 10 years ago. And basically what it does is that when we have some data from a previous layer, we pass it through 3 different branches. And then each of these branches picks up features at different scales and different levels of abstraction, and then we concatenate them together. And these 3 layers were followed by regularization blocks. And the purpose of these is to make the model more robust and to make it, more generalizable, hopefully. Okay, so that is for the network itself. And now on to some results. So the IED net itself achieved a relatively high accuracy. And for IEDs specifically, because remember, it was trained to distinguish between IEDs, artifacts, and others. For IEDs specifically, it achieved a very, very high performance, which is very encouraging. And the figure you can see on the right is basically what the model does when we feed it an IED. So if we go back, we have 3 inception layers, and we have 3 branches for each inception layer. So here, basically, this is for each layer, the different branches. And this is only some qualitative analysis that we did on the data itself and on the model. And this can be done on a much higher level with much more detail in the future. What we notice is that, for example, for an IED, when we pass it through the third layer, we always see 3 waves, which could be indicative of them. And then we see only for IEDs, not for artifacts and background, which can be indicative that the model is actually learning that this is an IED. And this is just one of the things that we noticed. And what I can also say is that it is encouraging that only at the third layer we can see it, and there isn't that big of a difference at the first layer, because that would mean that it is relatively easy to distinguish between, for example, IEDs in a neurotypical or an artifact, which I already mentioned is quite challenging. So these results in that sort of sense make sense. Okay, now it is important to recognize that even though these results were very encouraging, and that there are some limitations. And the first one being we need to validate this model and to make some design changes. So what happened after I finished my master's is that the team got data from the Kenya site, and obviously our model, the accuracy of our model dropped significantly, which we expected to happen, and that can be for multiple reasons. One of the reasons was that the electrodes could fail. There was a much higher humidity in Kenya than that the humidity was for the data set I trained it on. So that is one of the reasons. Then they changed the electrodes to mitigate that. And another thing is that the level of noise was much higher than the one in the TUH data set, which also makes sense because this tool we're using remotely, we're not recording in the hospital, whereas for the TUH data set, it was all done in sleep studies where people just came in and then they were the only people in the room, so there wasn't as much sources of noise. So this was very, very early stage of development, but the next step and what happened after I left is that we retrained the network with new data. The performance was again better, so the model adapted to this new data, and we do need to validate it on other clinical sites as well. But this is a process that takes a lot of time and have multiple iterations to make it robust and to make it suitable for the different sites. Okay, so this is the summary of what I covered today. So hopefully that did make sense to give you a little bit of insight on some of the challenges I faced even during this early stage development. And that would be it. So I'm very happy to take on some questions, and thank you for listening.
Excellent. Thank you so much, Katerina. I already have 2 questions for you, right? The first is, one of us, for our participants, is wondering if you might consider doing this for Parkinson's disease in the future.
Yeah, it's an excellent question. I don't know whether it was targeted specifically to me or like to people in general, but it is possible probably to do. The reason why we chose epilepsy is also partially because the prevalence was high, and also because it is relatively easy to detect it from the EEG. We know what we are looking for epilepsy specifically. I can't comment too much about Parkinson's because I don't know much about it. I'm just an engineer. But if there are some features that we are looking for in an EEG for people with Parkinson's, we can probably do it. But I do know that there's some exciting research using wearables, for example, to use them for Parkinson's, for detecting early stage of Parkinson's, which can be suitable to this application. Yeah.
Oh, excellent. There's a second question. Someone is asking, how do you keep the confidentiality of the data sets beside making them anonymous?
That, again, a really, really good question, because it is not that easy to do that. So when we talk about confidentiality, we can talk, about anonymization. And that's what I said. So we try to remove the patient's name. Anything that we that can easily identify them, we don't use them. Another thing that we do is try to use the least amount of data that we need. So if we don't need a specific thing about a patient, we won't use it. Then you can have, there's so many things that can be done. So we can use secure servers that is also need strict access. You control who has the access, and even within a team, not all people will have access to the same amount of data. And it's also like another interesting thing is, for example, that what means anonymization in one context might not be anonymization in another. So if you have, for example, an area where there are quite a few patients with a rare disease, removing you might not have to remove that diagnosis in order not to be able to identify patient. But if you have a country where that is the only case within a country, if someone knows that there is a person that has that particular disease, that is an identifier. So it is a topic of discussion, and it is easier done like before when you analyze the data, when you incorporate that analysis from the beginning. Yeah.
Excellent. Thank you so much. Please keep your questions coming in. Katarina will answer the remaining two. There are questions waiting for you in the chat, so you can pick them up and continue. Thank you so much.
Thank you for having me.
Excellent. We'll move to our final innovation for today. First, we've seen how AI can help us to make sense of data. Second, we've seen how AI-based solutions can help clinicians to provide better care, potentially lowering costs and all of that. The third project we're going to look at is particularly exciting for me. And we have Stanislaus from Jacaranda Health in Kenya, who will tell us some very exciting things AI-based solutions are doing within the maternal health space. So Stanislaus, I'll hand over to you now.
Thank you so much, Prince. So my name is Stanislaus Mundela. All right. So my name is Stanislaus Mungela. I work at Jacaranda Health. I'm the machine learning engineering manager, and I'm very excited about today's topic. So we'll be talking about how we improve maternal healthcare outcomes in Kenya using artificial intelligence. So just a brief history about Jacaranda Health. So Jacaranda Health is based in 3 countries. We have operations in Eswatini, very small operation, operations in Ghana, but most of our operations are currently in Kenya. Our mission is to develop low-cost solutions by partnering with government so that we can reduce maternal mortality, and also to ensure that we have good outcomes for the people we serve. Then I'll start by giving you a story. So this is a story of Josephine. So it's not a real name. So Josephine is a mom based in rural Kenya. And she's currently in 3rd trimester. So one evening, she starts experiencing bleeding, and she thinks that this is not a serious issue, it's going to stop, and she does not seek care at that time. But the bleeding does not stop, and she's forced to go to the hospital. But there are also some delays which occur there because her living in the rural part of Kenya, the transport infrastructure there is not well improved. So the ambulance takes like 1 hour to come. And by the time she gets to the hospital, her outcomes are not very good. So that's where we come in at Jacaranda Health, where we want to ensure that mothers are able to get this information they're trying to seek and be able to identify these types of danger signs before they become worse. And Josephine is not alone. So that 3% of maternal deaths in Kenya are caused by delays in care seeking. And over the years, Jacaranda Health has been able to develop this tool called Prompts, where we partner with around 1,000 public health facilities in Kenya, in 22 county governments, And currently we reach almost half the population of mothers in Kenya. That's like 2.4 million moms. So this is how prompts works. So I'll still use Josephine. So Josephine sends up for information and advice on an SMS platform in the nearest health facility. So most of our services are in SMS, and partly the reason why we use SMS is because the mothers we serve are underprivileged. Most of them can only afford feature phones. So they can't afford smartphones. So the only way we can communicate with them is SMS. So Josephine sends up for information, sends up for prompts via SMS, and usually do the enrollments in our healthcare facilities. So what we'll start doing is first we collect our data on pregnancy month, so that you can tell if she's 2 months pregnant or 8 months pregnant, and then we can now target we can target our messaging such that if it's 8 months, there are some things which she needs to observe. If it's 2 months of pregnancy, some of the information she needs to know. And from that, we start also receiving interactions from Josephine and moms like her. So they sent us questions, and in a typical day, would receive at most like 5,000 questions. And that's where our machine learning comes in, so that you can now be able to address these questions which are asked by Josephine and moms like her. Just a minute. Right. Okay. So this is the volume of the questions we receive in a day, over 5,000. And the challenge here now is to identify the serious issues out of these given questions. So as depicted here, you'd see that on one end, we are getting a lot of questions on nutrition. On the other end, things like postpartum depression or even miscarriage. These questions are not also well represented in our data set, and we want to be able to tell these things with some level of urgency. So machine learning now helps us to be able to triage. The first step is our classification model, which will help us to triage these questions into different categories, and then be able to assign the urgency. So the challenge is the data, as I also mentioned. So look at this graph here. So we don't get a lot of depression questions. We don't get a lot of miscarriage, baby loss questions. But these are very, very serious issues. On the other hand, things like diet, nutrition, we are getting a lot of questions, and which we deem that a category like diet, nutrition, most of these questions do not need to be addressed with urgent priority. Since even our help desk is limited, so we only have 15 help desk agents, and they're supposed to address 5,000 questions. So what we have done is first we created a classification model, which enables us to detect with a very good accuracy the category which this given query falls under. For instance, let's look at this first journey. So the mommy is asking, is it okay to eat avocados when pregnant? So this will go to the model, and then it's going to identify with like 91% accuracy that it belongs to nutrition. But more specifically, we also want to know what kind of nutrition is this concerned about. Is it avocados? Is it milk? So our classification models have been built to also model hierarchies. For instance, when you look at things like pain, I want to move to the next level and know, is it pain leg? Is it pain lower abdomen, etc. So this level of granularity also helps us in also trying to also assign that given urgency, and also reduce ambiguity between the categories of the questions. So initially, before we developed our large language models, we would, after identifying this question with a acceptable confidence level, like avocados, would assign a suggested response like eating avocados when pregnant is okay, etc. But now we saw that these suggested responses were not capturing the context of the questions quite well, because maybe someone is trying to ask even something like, what are the benefits of eating avocado while pregnant? And that necessitated us to build our large language models, which I'll also discuss in the next sessions. So in the next slide, I'm going to show you a question which requires urgent attention. So we have this question from the mom. So I have a headache that lasted for many hours. So first level of classification will detect that this is headache. And then the second level will now tell us whether it's severe or mild or moderate. And then if it's severe, it's flagged as urgent. And for all those things which we deem as urgent and as danger signs, we have to call the moms. So one of our desk agents will get in touch with agent, and they will discuss with the moms on what actions they should be able to take. But if it's not urgent, or it's just moderate or low priority, we'll mostly send a response to that given query. So the challenge has been first the language and the context. So when you look at the language, most of the questions we receive are mostly code mixed. So most of the moms we interact with usually use Swahili, but also a slang or a Creole we call Sheng, which is a mix of Swahili and English, and also other local languages. So when you look at this type of language, it's not well represented in the standard NLP models, that performing models, or NLP corpora. So we'll to build our own solutions, our own classification models, which could well understand this given language. Again, also, when you also look at the context, it's not the general knowledge, it's maternal health care discussions where we have like some specialized vocabularies in local languages. Yeah, that's those are two of the challenges we had to solve. Now, if you remember, I mentioned that before we released our large language model, we were mostly using what you call the instant responses. So detect an intent, then assign an answer. So the mom is asking about avocados. So of course, we want to attach a pre-written response on avocados. But that was not very effective in addressing the context. And so we first tried to use off-shelf LLMs, ChatGPT and the like, but they were not quite good enough. I'll give you an example. There's this fetal movement question we gave in Swahili, but the generated response was on a baby playing, and you know the implication of this. So the mom is trying to ask about fetal movement, and the response we are trying to send is on a baby playing. So we needed to be very sensitive on the kind of responses which go to the mom. And that's what I'll be talking about in the next slides. So to contribute to that, we did not wait to catch up with technology, or so we did not wait the technology to catch up with us. So we decided to create the technology in-house, and last year, September, we first released a Swahili large language model, what we call the Uliza Llama. So a very performant large language model which understands Swahili instructions quite well, and also answers Swahili questions quite well. But we also needed to also fine tune it now to understand a maternal healthcare discussion. So this Swahili large language model, it's based on Llama. So Uliza is a Swahili word which means ask. So that's how it came about. And Uliza Llama was fine-tuned now to be able to handle maternal healthcare discussions. So, and this gave us to what we call the Uliza Mama. So Mama in Swahili means mother. Uliza, as I mentioned, means ask. So now we created Uliza Mama from the extension of Uliza Lama, so that we could be able to address Swahili maternal and newborn healthcare queries. So for instance, there's this question here. It's in Swahili, but we have translated it. So the question is, I have a stomach ache, and then this is what the model generated. So stomach pain, because it's within this domain, so it will say stomach pain is typically caused by the expansion of the baby's sac and the stretching of the ligament as your belly grows, hormones, constipation, and trapped gas. So it's advisable to go to the hospital if you experience severe cramps, excessive pain that starts suddenly, feelings of nausea and vomiting, bleeding from the genital area, fever, or if your baby is not moving as usual and you're more than 28 weeks pregnant. So as you can see, very, very good response. And usually when you're trying to provide this kind of prompts, you don't just give it the first part, like I have a stomach ache. So you also have to add some context, such as, is it before pregnancy or even after pregnancy? This is another example. So the mom is asking whether it's okay to eat avocado, and it tells the mom that it's okay to eat avocados in pregnancy, and also gives the benefits of why you should eat avocados, and and also tries to give some action steps on how to eat the avocado. So it's just essential to eat avocados at least twice a week to supplement these important nutrients. So after deployment of prompts, it's been active for like 4 years, but the LLM work, the large language models work, began last year. And as I mentioned, we created it in-house using open source large language models and trying to fine tune them. But over the time, prompts has been in service in our country's healthcare system. We have been seeing some proven impact on health-seeking behaviors throughout a mom's journey. For instance, moms who are on prompts, 27% of moms on prompts attend the recommended 4+ prenatal care checkups. So, and also moms who are on prompts are 2 times more to take up post-family planning services. And 89% of moms on prompts are able to follow some of the advices, such as ensuring that they exclusively breastfeed for the first 6 months after delivery. So we also want to leverage on our prompts infrastructure to expand impact. So we are currently now exploring how we can be able to customize it for new domains. So currently we have been mostly in maternal newborn health, but there are other verticals which you can also look at, like things like malaria, HIV, NCDs, non-communicable diseases, etc. Then we're also leveraging on our infrastructure also to customize it for new languages. So we recently customized it for Twi. Twi is a language in Ghana. And soon we'll be doing that for Amharic. So when we expand our operations to Ethiopia and also have a local dialects. Then we're also trying to look at ways of also trying to customize it for new use cases. So we're also trying to establish how speech to text and text to speech solutions can be implemented within this given pipeline. Again, we also believe that we can also be able to deepen the impact by customizing the patient journeys and the risk profile. So we collect a lot of data from our moms. For instance, we know how many pregnancies they've had, history of preeclampsia and all that, and even some demographic information. And from that, you're starting to build some personalized risk profiles, which now allows us to personalize the kind of messages we send to moms. So we're also trying to actively grow our footprint. So currently, a lot of operations are in Kenya, but we have been pilot testing feasibility of prompts with the Ghana Health Service. And we also have a project in Eswatini in partnership with Chai. So that is it about prompts. But just to also make it clear, we don't want large language models directly talking to moms. So we're interested in trying to have a level of moderation when it comes to using large language models for healthcare use cases. For instance, what we do is when the LLM generates the response is not directly sent to the mom. So the response goes to our help desk and then it's moderated before it's sent to the mom. The reason being, we want to ensure that this is done in the most safest way. And but the idea of the LLM generating the response is actually to reduce the response time it takes for an agent to answer a given question. So given a response, they can simply edit it and send it out. Thank you so much. That was my presentation.
Thank you so much, Stanislaus. I'm sure there are so many excited people waiting just to ask you questions. I have about 4 questions here now. And you can start taking them one by one. The first one is asking, can you describe your evaluation framework for your model? Did you adjust metrics over time? And finally, did you have a minimum threshold that needed to be met prior to rollout?
Thank you so much, Prince. That's a very good question. And even for anyone else, anyone working in the LLM evaluation is a big, big thing. And also, it's how do you even evaluate these large language models? It's a very good query. So one of the approaches we take in trying to evaluate these large language models is by trying to define a structure of what information we want to use in this kind of evaluation. And for us, like Jacaranda Health, we are using the structure which is used by our quality assurance team. One is trying to assess if a response meets some certain criteria. Some of the criteria our quality assurance team looks at is the completeness of that response, which the agent gave. They also look at how factual is it. They also look at did they identify whether this condition is normal or abnormal? Did they also give like some medical explanation to these? And in a way that also the mother can actually understand it. So, and all this is semantics. So now the way we actually do this is even before releasing the model, we do the audit using other large language models. Like for instance, we use GPT-4. GPT-4 is actually very good in Swahili to even assess how good are these responses given these audit criteria. Now, the other approach was also to look at the questions which have been done this month. So our help desk has responded to these given questions, which the model has not seen. So we give the model, it predicts the response, and then we try to do that comparison of what the model has said and what the agent actually said, and try to see if there are any differences. And of course, there is a threshold on when we say that this is actually okay and that is not okay. And it's all based on the audit score metric.
Excellent. I think to dig a little bit deep into what you mentioned, there's a second question about, could you clarify whether your LLM models are developed using technologies from OpenAI or such as LLAM2, or if there's a different foundational approach to how your models are created?
Thank you so much. So we are not using OpenAI to create our model. So we are building them by extending existing open source large language models. For instance, when we were trying to create these Uliza Mama, we started first by trying to create Uliza Llama, the Swahili version. And Llama Llama itself is an open source large language model created by Meta. But you find that it was not pre-trained with any Swahili, so it doesn't understand Swahili at all. So our approach was first trying to continually pre-train, just continue pre-training it to understand Swahili, to learn Swahili, and then also using some instruction data sets for it to also learn Swahili. Then after that, we now continually pre-trained it now to now also understand maternal and newborn health nuances in Swahili and also English. And then after pre-training it, we also gave them the instructions. So we have like a data set of 1.3 million questions and 1.3 million responses. So we use that to actually train it to understand how to respond to these given questions. Yeah.
Wow, excellent. There's a question here. I presume this would be from Kenya. Does your SMS respond to Sheng if text is set Sheng?
The responses will not be in Sheng, but the model will be able to answer questions in Sheng.
Okay.
But we will not provide the responses in Sheng.
Sheng.
Yeah.
Excellent. Just out of curiosity from me, in your opinion, what has been the biggest challenge in rolling out prompts?
Yeah, so the biggest challenge in rolling out prompts or the LLM model?
Prompts. Prompts.
All right. I think it takes a lot of time to create these kind of partnerships with government, because we partner a lot with the government. So without these partnerships, we will not be scaling our solutions as it's scaled right now. So building that, those kind of partnerships, all the compliance, like in Kenya, you have to do a lot of data compliance, and I'm happy we got the data processing and the data controller certificate. So I would say the biggest job is actually not even the technical part of it, not the technical bit of it. The biggest part of it is all these external factors you cannot control, regulations, and again, also trying to build the partnerships with the government, trying to have someone who can actually push that given product in the market. Yeah.
Excellent. Thank you so much, Stanislaus. Please keep your questions coming in. The panelists will respond to all the questions either after the event or right before we come to an end. So thank you so much, panelists, for a wonderful discussion. I'd like to remind us all of some very important things as we bring the workshop to an end. First, if you wish to receive a certificate of attendance for this workshop, please complete the Global Health Network Workshop Feedback Survey. Secondly, you should have spent about 80% of your time here, 80% attendance of the workshop. Please include the title of the event, and please note the code 130224, 130224 when requested. That is the code right there, 130224. Your certificate will automatically be emailed to you within a month. Before we leave, I'd like to mention that this is just the beginning. Stanislaus ended by mentioning how the regulations can be quite challenging. Next week, we're going to have a discussion on the ethical considerations when designing AI-based solutions. And so it's very important that you are around as well next week. We'll talk about the ethics of designing AI-based solutions. We'll talk about frameworks and policies that currently are in play, focusing on WHO policies. And then we'll look at an in-house developed quality assessment framework for ensuring that all AI-based solutions are responsible. And so Thank you very much for being here. Thank you for your participation. Thank you so much to the panelists. We received many comments and questions, and we'll gather all these together and we'll bring our panel to respond to them in writing. Please note that a recording for this session will also be made available on the Knowledge Hub. The link has just been posted in the chat. Thank you very much, panelists, and to you all for your participation. We will now close this session.